Hello, everyone. My name is Andrew Jack from the Financial Times, and it's a great pleasure to welcome you all to this latest in the COVID series, episode 61, Allocating Critical Care and Scarce Resources in the Pandemic. So over the next 45 minutes or so, we're going to discuss with three experts and very keen to hear your perspectives and specifically questions. So I'd encourage you to use the Q&A chat function from now on, and you can also upvote others' questions, and we'll try to get through as many of the issues and questions as possible that you raise after some initial discussion with our guest today. So we have Dame Jane Dacre, the President of the Medical Protection Society, former President of the Royal College of Physicians and Professor of Medical Education at UCL, Dr. Moosa Qureshi, a Consultant Haematologist at the Cambridge NHS Trust, and Professor Tim Cook, Consultant in Anaesthesia and Intensive Care Medicine at the Royal United Hospital NHS Trust in Bath. Let's begin maybe with Tim, and perhaps just a little perspective if you'd give us on the clinical front line at the moment and how it feels and in level of the pressure and the decision making that's having to be made by you and colleagues currently compared to how it's evolved over the last few months and maybe compared with past surges that we see in admissions to hospitals.
Thanks, Andrew. Well, it feels very busy. So in normal circumstances, I'm predominantly an anaesthetist, and I do about a third of my time in intensive care. I've had an interesting pandemic. In the first 3 months of the pandemic, I was sent home because I have a chest condition and was not deemed suitable for work. And so I've only been back since July. And in this second surge, so I've observed a bit from the periphery, and then I've been part of it for the last 6 months or 7 months. And it's extraordinarily busy. So in our hospital, we built a second intensive care early on in the pandemic, and we run two hospitals, two intensive cares, both of which are extremely busy. There is the stress across the country varies by region according to time. And I work in the southwest in Bath, and we were probably the most lightly touched by the pandemic in the first surge, but we were very heavily affected. And in the second surge, we've also been one of the less affected, but also been running well above capacity, with many intensive cares running at 200% normal capacity. And the particular feature, or one of the very big features that's happened in the second surge, has been a dramatic increase in relocation of patients from one hospital or one region to other hospitals in order to ensure that all patients who require intensive care can receive it. And that's a change that is perhaps worth discussing a bit later, but it's very dramatic. But I'm on call tonight. I'll be in the hospital resident. That's not normal. We're running a surge rota with, instead of one intensivist working in the hospital, a consultant intensivist working in the hospital, 4 working each day, which means that for the 12 of us, obviously we're covering a lot more activity than when we were also doing anaesthesia and intensive care. So it's extremely busy. It's hard work.
Sure. So Jane, give us a little bit of a perspective from what you're seeing about the intensity of admissions and the challenges around triage.
So my specific role is more of a backroom person. So what happens is that my colleagues who are younger than me and more involved in acute medicine have all one by one been called into the wards to help with the COVID outbreak and put on rotas. So anybody that has any training that involves being involved in the acute care of medical patients has been redeployed to be on the wards. That has also, in fact, included our medical students who have provided the most extraordinary support working as healthcare assistants on the intensive care units and also in the wards. So where my more junior colleagues go into helping out on the wards, what I do is pick up their clinics. So there's a system where we pick up the outpatient service remotely so that we make sure that patients with long-term conditions don't suffer unduly. So there's been a lot of pressure. There are big problems mainly with staffing, because I think as we have certainly said at the Royal College of Physicians, we don't have enough doctors in this country for normal times. But then when you add into that these relentless rotas and people being off sick, either with COVID or shielding or self-isolating, there are very significant staff problems, which is why we've made a decision to get support from our medical students who are volunteering and doing a fantastic job.
And your point would be that actually then the pressures are being felt, and indeed the need for triage, as it were, throughout the system, and obviously not just in intensive care, for example.
So the pressures in relation to patients have changed, because in the first wave, it was thought that treatment in intensive care was something that should be offered to a larger number of people. But as the outbreak has moved on, it became clear that high flow oxygen and management on the wards was in fact more appropriate for some patients. So that decision-making process has been extremely dynamic. But what that's brought with it for my colleagues on the acute wards is a different set of problems related to, for example, oxygen pressures or number of CPAP machines, and allocating the most appropriate care to the patient who is in need of it and likely to benefit from it most. And that's been a very difficult thing to come to terms with.
Moosa, so you have some frontline experience, but also a lot of reflections around the issue of the level of protection, legally and otherwise, around clinicians, don't you? And what's your current sort of take on the situation?
So, Andrew, I'd like to just start by clarifying I'm not working for Cambridge NHS Trust. I did my PhD at Cambridge, but I've done all my work as an NHS doctor in London. I'm a hematologist. To some extent, I've been protected, obviously, from the intensive care work that Tim has seen. There has been a complete reorganization of the NHS, I'd say. In the sense that a lot of resources have understandably been diverted to intensive care. I think that has meant that other services have suffered. And one of the main challenges, for instance, we faced is, for instance, maintaining cancer services. And I know other specialties have had challenges as well. I think we've managed to do that. But I think one of the things we really need to reflect on as well is the huge numbers of deaths in intensive care, we also have significant excess mortality during this pandemic, which is not explained by COVID. And the concern is that obviously other services in the NHS have suffered, and that has resulted in significant mortality as well. In terms of your question about my sort of other involvement in terms of the legal kind of ramifications of this pandemic, there are significant ethical and legal problems that have arisen due to this pandemic, and I feel that we have not, as a profession and also at a more senior sort of governmental level, fully grasped the nettle with regard to those.
So we'll come back to some of those issues about protection and guidelines in a few minutes. But first, let me go back to Tim. Just put this into context for us, thinking about the different approaches to triage around population, around capacity, how the current situation and approach differs perhaps from normal medical triage.
So in the normal circumstance, I personally wouldn't use the term triage for what we normally do. I'd refer to it as decision making. So in normal circumstances, in all aspects of medical care, but in my case for critical care, we have to make decisions as to whether a particular treatment is suitable for a patient, and therefore to consider whether they would benefit from it. And that involves a knowledge of the potential benefit that the patient may receive from the treatment, the burdens of that treatment, and the likely outcomes. And that needs to be balanced in an open and transparent discussion with the patient about what their goals and expectations are, what they would wish for in terms of perhaps the intensity of treatment, what they would wish for in terms of outcomes, and what they're willing to go through in order to reach those outcomes. And then one can reach a balanced decision with the patient as to whether, in this case, critical care, which is extremely burdensome treatment, and which is often not followed by a return to previous quality of health, is in their interests. The area of interest that's arisen for concern and anxiety that's arisen since March is the issue of population triage. And that is when demand exceeds, people generally say capacity, but I think capability is a better term. So where demand is more than the service can provide. And the focus has, in my view, excessively been on critical care. Only 1 in 10 deaths in the pandemic occur in critical care, but the focus has been very much on critical care. And then if demand is demonstrably greater than capacity, then extraordinary actions have to be taken. And there may need to be decisions about deciding between patients who both could potentially benefit from the treatment offered, and deciding when there is only sufficient treatment to offer it to one person, who should get it. And that is then population triage or triage by capacity. And that's something which is completely alien to my normal area of practice, and something that hasn't been needed in my area of practice in this pandemic. But it's a topic worthy of significant discussion.
And are there any sort of guidelines already in place that you're able to use?
So in the flu pandemic of 2008, 2009, there were similar concerns that the NHS would be overrun by the number of patients, and some triage documents were drawn up, population triage documents, and they generally related to severity of illness of patients and fairly broad stroke views on how likely patients were to survive. But the COVID pandemic is rather different, particularly because in contrast to flu, it very dramatically affects older patients. And with that comes comorbidity, frailty, and the changes of age itself. So there is a more urgent need to consider all those factors in terms of prognosis, wishes, expectations, and our ability to return patients. So the short answer is, from the centre, there is no clear guidance. There have been a series of documents that have been produced from the Royal College of Physicians, from the BMA, from the Intensive Care Society, and from NICE, all of which have value, but they tend to be either based on individual triage. Does this patient need intensive care? And they assume capacity, or they are sort of fairly high-level treatises on ethics. And what we produced in Bath, which I think is probably why I'm on this discussion, is we produced a discussion paper to try and operationalise that decision-making. As was said by a government minister, these decisions need to be made by doctors at the bedside. And we tried to produce a document that set out the sorts of principles that might be used in order to do that. But we importantly have not used that as a document within our hospital. It's not hospital policy. And the document we published in the Journal of Medical Ethics was a discussion document with a specific aim of creating discussion around this topic, because frankly, the decisions are too important for doctors to make alone.
Yeah, and perhaps very briefly, but one or two of the key recommendations you make in that document.
Well, we set out a pathway, really, a pathway to work with the patient and the family to work out what's right. So we do a lot of things which are normal. The first step, 5 steps, the first step is to establish that demand is exceeding capacity. So this is only to be used in the circumstances of a lack of resource. It's specifically a document for that. I'll emphasise again, it's not in use, it's a discussion document. The next step is normal medical care, which is assessment of the patient. How sick are they? What's the prognosis from the condition? Considering their age, frailty, comorbidities, functional capacity. A discussion with the patient and the family about their perspective, the clinician guiding them through what coming to critical care might mean. And then a specific pause to think about the ethics when there are more need than there is capacity, and a specific ethical framework that we require, that we would require those using this document to go through to establish what is ethical. And that's really partly where the broader discussion needs to lie. And then the last bit is again normal medical practice, bringing those discussions together. There are certain scores that are used, but the scores are used not to define actions, but to guide or assist in decision making. And we specifically avoid making decisions on the basis of a given clinical frailty score or individual age. The point is that there does need to be decision making. It's useful to have ethical principles, and the only way I could think of it is if you reach a road, there's a junction in the road, and you have to get to the end of your journey. You need to get somewhere. There's a I don't know, a fire behind you. There are lots of documents that talk about doing the right thing, making the right ethical decision. But actually, as a clinician, we need to make the right decision. We need to make a decision. We need to travel down one of those roads. We can't just sit there at the junction. And the document is designed to help that. But importantly, this is not individual decisions making this. We don't have a triage committee, or we don't suggest a triage committee, but we do suggest that a minimum of 3 senior doctors should be making decisions in these unenviable and very difficult circumstances.
Okay, and I'm sure we'll come back to some of the nuances of that. But Jane, what's your reaction? Do you see the need for some sort of guidelines, perhaps along the lines that those Tim has laid out?
I think the guidelines are terribly helpful for individual clinicians. I think maybe something that I should stress that we do as the patients come into hospital is to make sure that the patient and their family have had some kind of discussion about what we call a treatment escalation plan. So as the patient arrives, there is discussion, a what if discussion with them and with their families, so that you make sure that before they become too unwell to contribute to that discussion, that has been had and it's been documented and it's in the notes. And so then when you go on, knowing what the patient and the family's wishes are is terribly helpful to help people to make those decisions. And similar to in ITU, what we've set up in our hospital is a position where there have to be 3 clinical decision makers. What we also have is an ethics group, and that group meets weekly, and we are also on call, so that where there is a difficult decision, those decisions can be discussed with a group of people or a person or 2 on call that can help to make that decision. We're an advisory group. I'm on call for it this week, but we are an advisory group because the person that's most likely to be able to make that right decision about which road to take is the person who's looking after that case in conjunction with the patient's family. These are incredibly difficult decisions.
And Moosa, so talk now a little bit about your past experience and thoughts about whether we do need some degree of additional guidance or indeed protection for physicians on the front line to mitigate the risks of any personal liability, amongst others, from their decision making.
Yeah, thank you very much, Andrew. I come at this from a very different angle, which is I've been involved with a series of legal cases where things have gone very badly in the NHS, and those cases are of importance for what we're discussing today. So the first case I was involved with was a case of Dr. Chris Day, who is an ICU doctor who was working in a severely understaffed intensive care department, raised concerns and subsequently lost his career. And the second case was Dr. Bawa Garba, where I was one of the main crowdfunders for that case. And that was a very different case, almost the opposite. It was a doctor who didn't raise concerns, but was working in an NHS trust with some quite serious systemic issues, which they admitted themselves later. And she was subsequently, following the tragic death of a young child, convicted of gross negligence manslaughter. And I think that there's a significant concern, which perhaps Doc hasn't sunk in really for medics on the front line, which is that unless we have proper government guidance, then doctors are going to, if there's a population triage situation, doctors are going to be having to make decisions which expose them to significant legal risk, including battery and potentially its worst case scenario, manslaughter. That's not just my opinion. That's a group of legal experts from the University of Cambridge, led by Dr. Cathy Liddell, have written extensively on this, and it's been published. So I really think that we do need some government guidance. And if you read all the literature out there, it's very tentative. So Tim Cook's done an extraordinary, I think his piece of work is extraordinarily important. It's brought to the fore an important issue, but it says, repeatedly, if you read that article, it keeps saying, this is just a discussion paper, this is not policy. And obviously, rightly so, because he's not in a position, none of us are in a position to make that kind of decision. That sort of decision has to come from an authoritative body. And even the BMA, Cathy Liddell's group, points out that the BMA is not an authoritative body. They've got some ethical experts, but they cannot say to doctors, if we're in a situation where we have to, and the worst case scenario, which I think Tim discusses in his article, is a situation where you may potentially, if a pandemic gets really bad, you may have to unplug a ventilator or remove ventilation from one patient to give to another who you think would benefit from it more than the patient being currently ventilated. And that brings all kinds of legal problems. Potentially you will have made a decision consciously which has resulted in the death of a patient who you've decided yourself through no criteria, no official criteria in any case, would benefit less than the patient that you've decided should be prioritized over them. So really, we seriously need some official guidance about this.
And are there, you worked, didn't you, on getting the release of the Exercise Cygnus files? Are there any messages out of that that are relevant currently, do you think? Exercise
Cygnus is really interesting because what it was essentially a national tier 1 exercise, which was designed as a learning exercise. NHS England said just before the exercise that they intended to publish the findings. It involved 44 agencies throughout the country. It was extremely complex, extremely comprehensive, and yet the government decided not to release the findings of that report. Even today, what we've managed to uncover to date is a report from Public Health England, which bizarrely has almost no mention of ventilators, no mention of PPE, no mention of intensive care capacity, even though NHS England was significantly involved in this exercise. And you have to think, can it be that a national pandemic exercise found nothing about ventilation capacity or intensive care capacity? The whole report, to me, leaves lots of questions unanswered. But one of the interesting aspects of that report is that there are 22 lessons identified during that report, and the government has consistently said they acted on all those lessons identified. One of the lessons identified was that we should create a national population triage strategy for the NHS. So on the one hand, the government has said that they've done everything that report said they should do, which suggests that there might be a NHS population triage policy somewhere that they have written up, but they're refusing to disclose it to the medical profession, the people on the front line. And that raises some serious questions in my mind.
Absolutely. And of course, the whole exercise Cygnus wasn't even released, was it, until a few months ago, long after the original policy recommendations were supposed to be being enacted.
Yeah, no, rightly so, and only after significant legal pressure from our team at Lead A. So it's, for all of us as medics, we're taught to be transparent, to share information, and to follow guidelines. But we really need that at every level, not just at the front line, but we need it right from the top down if we're going to deliver healthcare effectively in this country.
So thanks so much, and we could discuss these in a lot more detail, but I should really turn over to a few questions now from viewers, and these will touch on multiple different areas. Maybe initially here, and perhaps I'll turn to you, Jane, initially. So what work is being done to decompress the units in greatest need?
So actually, I suspect that Tim's probably best able to cover that. But what's happening, which didn't happen so much in the first wave, is that where ITUs are starting to reach capacity, patients are being transferred to a different hospital. That's certainly happening in London, and in the gap between the wave in the spring and the wave that's going on now. People made extensive arrangements to work out the criteria for and how they would transfer ITU patients if a hospital looked as if they were becoming overwhelmed, not just for ITU, but also where things like oxygen supplies and bed capacity was being a problem. So that's helped to decompress. And then, as I mentioned earlier, doctors and nurses are being redeployed. So in order to support the staff who are delivering the frontline care, people with generic clinical skills are being put into wards and also the ITU to be able to support. And the sorts of things that they're doing are helping to prone patients who need to be proned in order to improve their oxygen supplies, working with the anaesthetists to help to support them, drawing up drugs, giving drugs, doing charts, keeping charts up to date, working as healthcare assistants. So people who have clinical skills, who are doctors or other healthcare workers, are working actually outside of their comfort zone, whilst being supported by the teams that are specialists in that area. Because we, as I've said before, are understaffed with specialists and also intensive care beds and all beds in this country. And so people are having to broaden their area of work to outside their comfort zone, which brings with it its own problems. Particularly, I want to flag up the issue of medical student volunteers, who are doing the most extraordinary job in ITU and all over the hospitals. And depending on their level of clinical competence, they're being asked to do all sorts of things that they haven't done before. We don't want to stop the next generation of doctors from being trained. So at the same time as that, we're asking them to continue with remote learning and to continue with an apprenticeship style training. So they are working to support the people with the real skills, but people like Tim who are actually delivering care on the front line.
Tim, so switching to you on that decompression, and also there's a specific question I see for you about when you said 1 in 10 deaths in the pandemic were in critical care. Is that only COVID deaths or all causes of death?
Specifically for that, that's COVID deaths. So picking up on what Jane says, I agree very much with what she says. So in terms of capacity and demand, in terms of preventing the NHS being overwhelmed, which it would have been without the actions that have been taken, undoubtedly. I like to think of the 4 S's for critical care, but it involves elsewhere. So you need space, you need somewhere to deliver the care, you need staff, you need systems, and you need stuff, which is equipment. And you can run out of any of those, be it oxygen, be it staff, be it physical space, or systems that work. And to balance this difficult difference in capacity and demand has been the big challenge of the last year. And the government, the things that have been done in many ways have been hugely successful. So the demand was dramatically decreased by two things, by lockdown and by the behavioural changes that people have made. And that dramatically decreased demand in Surge 1. And then the other way demand was decreased was to stop all other healthcare apart from COVID, essentially, in March and April. And of course, that had to restart. And as Moosa said, there have been excess deaths beyond COVID, and it's morally and clinically appropriate to re-energise that work. And that has had to be paused again to a certain extent. Elective surgery was dramatically impacted in December and January. So I think in the first surge, the biggest effort, as Jane says, to improve capacity was physical expansion of intensive cares and redeploying staff. And what's been bolted onto that in the second surge is a hugely successful effort to move patients when necessary between units. And that's not to move patients from one unit which is very much over capacity to one that is under capacity and has lots of room. It's actually an appreciation that within the region and ideally within the country, all intensive cares should be working at the same degree of stress. So if that means that all intensive cares are working at 180% of normal capacity, instead of one working at 250 and one working at 110, then that has been done. And that is a massive undertaking. It's a massive undertaking. So new transport systems have been built up. Previously, they only existed for paediatric intensive care, and now they've been established at a rapid pace to transfer patients by road and by air across the country. And I think it's been a huge success for the population. Now, there are ethical issues around moving patients in this way, but I think it has been a huge success. It's worth touching on the Nightingale hospitals. They were one of the major efforts to increase capacity. And the XL Nightingale Hospital, 4,000 beds, had the potential to double the UK's ITU capacity, broadly speaking. Of course, only a couple of hundred patients ever went in there. And the main reason for that, which a lot of people perhaps scratch their heads about, is because there were no extra staff. So they created only space and a bit of stuff, but they didn't create systems or staff. And so in order to transfer patients to any of the Nightingales, be it in Bristol or Manchester or London or elsewhere, it would require taking probably the most stable patients, but because of the abnormal environment, taking also some of the most senior staff to look after those patients. And that was generally thought, after some consideration by clinicians, to not be in anybody's interests. And I sat on the Nightingale subcommittee in our region for several months, and I spent most of my time saying we shouldn't, I support their existence in case the NHS fails, but I don't support their use until the point at which it fails in terms of using them for intensive care. And actually, I think the fact they haven't been used means that in broad terms, the NHS has used other mechanisms, the country and the NHS have used other mechanisms to maintain that capacity. And that is a success story. So actually, widespread use of the Nightingales would undoubtedly mean, in my view, a deterioration in overall quality of care, and would signal that the NHS had failed in its ability to provide critical care. And by and large, under enormous pressure, I think the NHS has risen to that challenge. And I absolutely agree with Jane. It's important to pay tribute not just to hardworking critical care nurses, dietitians, pharmacists, physios and doctors, but also to all those other people who have come in and done their stints, whether it be professors of pharmacology doing nursing stints or whoever it is helping out. It's been a huge, huge effort and something we should be proud of.
There's a very popular question here, which is a little bit off our subject of decision making, but around the vaccine and whether it's had a detrimental effect in disregarding protection measures or giving a false sense of security. I suppose one might add, is it creating any easing of the pressure also on admissions and intensive care? I don't know, Tim, any perspective on that? I
do have a perspective on that. I've actually modelled the impact. So the vaccine has a the vaccine policy that the government has a very rapid impact on mortality, and we're probably seeing that already. So the average age of patients who die from COVID is 83. The average age of patients admitted to hospital is 73 with COVID, and the average age of patients in intensive care with COVID is 61. So they're different groups, and the vaccination programme, including the special groups, that's healthcare workers, care workers, social care workers, high risk and extremely high risk patients. The impact of that means that deaths will come down very dramatically, but the impact on hospital admissions and on ITU admissions will lag. First, hospital admissions will lag by several weeks, and ITU admissions by even longer. These patients are incredibly complicated when they come to intensive care, and many of them require a month on intensive care on a ventilator, whereas normally your average time on ITU is 3 or 4 days. But these patients are requiring a month, maybe a week, but these are requiring a month. So that pressure on the NHS will continue from the model that we've created well into April in terms of admissions, and probably through to May in terms of the pressures on the system. And that's the best case scenario.
Jane, you might want to touch on that as well, but also there's a question here on a wider question for NHS staff and how far and for how long can they sustain the high level of workload and the physical and mental pressures that's imposing?
I think the pressures on staff are extraordinary and have gone on for too long now. And staff are beginning to find it really quite difficult to cope. The NHS and various voluntary organisations have done a fantastic job at supporting and bringing in food and doing all sorts of things to try and help. But there's no doubt that people are tired, people are fed up, and people are battle weary. There's this concept of moral injury, which is when, I suppose it originally came from the army, but when you have your moral conscience is peaked, and you feel guilty and you feel bad, and you feel bad about the patients that you weren't able to save, or where you made a decision and maybe you worry about it afterwards. And that's at a very high level amongst professionals, and it's been brought to the fore by my colleague Andrew Goddard, who's the current president of the College of Physicians, as being something that we really need to take seriously and somewhere where we need to support doctors. So that, I think, is made worse by this lack of clarity about what might happen to a doctor who maybe is under very difficult circumstances, involved in a decision that perhaps they might retrospectively think wasn't the most appropriate decision. Because in law, if there's a very bereaved family and a doctor or a group of doctors who are responsible, as Moosa has said, there is no protection for those individuals against criminal allegations. So the MPS, the Medical Protection Society, actually did ask the government. They wrote a letter with some other organisations, the Doctors Organisation, DAUK, and the BMA and BAPIO, asking for an emergency law that would protect doctors were they, through no fault of their own, in a situation where something happened for which they were being chased in the criminal courts. The government's response, which came into the MPS yesterday, said that they felt that because there was indemnity for everybody, that this law wasn't needed. But the MPS did a survey of 2,400 doctors. 61% of them said that they were concerned about facing an investigation as a result of a clinical decision that they'd made during the pandemic. So if you go to the regulators, the other people that doctors are concerned about and who do cause a lot of anxiety to the profession, what the healthcare regulators have said is we will take into account the context in which those decisions were made. However, one of the problems that Moosa pointed out with Dr. Hadiza Bawa Garba was that it was felt by the profession that they hadn't taken adequate account of the consequence. And all of those fears and worries and the exhaustion and working outside your comfort zone have an effect on the moral injury that doctors, nurses and other healthcare professionals are undergoing at the moment.
So there's a couple of questions I come to you on. First of all, I see someone suggesting the idea of a New Zealand style no fault compensation scheme. And then there's also, it's maybe going to legal technicalities, but someone's making the point that even in law and in professional ethics, decisions are not framed as deciding between patient A and patient B, just in terms of framing the context around litigation. Any thoughts on either of those points?
So obviously in normal medical practice, we don't make decisions between patient A or patient B. We always do what's in the best interests of the patient. What we're discussing today is a situation where you can't always act in the best interests of the patient. And unfortunately, I think, as Jane has pointed out, the GMC is our regulator. It's our medical duty to act in the best interests of the patient. In terms of indemnity and in terms of a no-fault system, I would be reluctant for that. And the reason I'd be reluctant for that is that there has to be some level of fault. Doctors have to have some level of accountability for their decisions. Although you would hope that in a pandemic situation, that level of accountability would be adjusted to take into account the circumstances in which we're working. What I really feel is that we need some, as I've said before, an authoritative government policy, which basically says that if you're in this situation, this is what you should do. In that sort of situation, I don't think a judge could convict a doctor of following that policy. It would be the government that would have to take responsibility. And I really feel that the government knows this. It knows this policy is needed. I don't know if they've written up a policy and they're refusing to disclose it because it would just be so, just raise so much public concern. But they know this policy is needed. And if they haven't written it up, they have a duty to the medical profession, who are putting our lives on the front line in many cases, to provide us with this guidance, because otherwise a GMC referral isn't an easy thing. There's data out there that significant numbers of doctors have committed suicide while they've been under GMC investigation. And a police investigation is much worse. So I have to come back to this. I think this whole sort of no fault or putting the onus on doctors or so on. I think these are escape mechanisms because the government doesn't want to do what is necessary in these circumstances.
Very clear. We're running out of time, but Tim, very briefly, a couple of points here. One is the question of whether you take into account patients' own views, such as, for example, if there's a living will already in place on treating, and secondly, just if there's a wider knock-on effect on ethnic communities when critical care is scarce.
So the first answer, in normal circumstances, well, in all circumstances, we take account of patients' views or the views of their advocates if they're not able to express them themselves. So be that a family member as an advocate or somebody appointed through the Mental Capacity Act or a legal representative when they've got legal power of attorney over medical matters. So yes, we do take those factors into account when deciding whether intensive care is the right place for somebody to be treated. In the circumstances of population triage, then again those factors, those individual factors and choices would be factored in, and they're part of our 5-point checklist in this discussion document. But it doesn't mean that people's wishes could necessarily be met. And that also applies normally that if somebody wants intensive care, even if they understand it, doesn't always mean it's the right thing for them. In terms of ethnicity, I think ethnicity is quite interesting. We know that there has been a disproportionate burden on I don't like the term BAME, but BAME groups throughout the pandemic, and the extent to which that's due to social geography or biology is uncertain, but a lot of it is due to inequality in social geography. And in fact, the ICNAR, so that's the Intensive Care National Audit and Research Collaboration Consortium, got it wrong, but ICNOT, which collects all the data for intensive care, was one of the early signals that there was a disproportionate impact on the non-white ethnic community. So there was an excess of particularly Black at that time, but also Asian individuals in intensive care early on in March. And that was one of the early signals of the disproportionate effect. Does it have a knock-on effect? I think perhaps the fact that there is an excess of individuals of non-white ethnicity is a good indicator that we in the UK are not discriminating in terms of whom we admit to intensive care. Obviously, should not be. But I think certainly one's ethnicity is not a factor in determining whether one is suitable or indeed should be admitted to intensive care. And I think we can be absolutely explicit on that.
Sure. So I'm afraid we're really almost out of time. We've heard from you very clearly, Tim, and also from Moosa about really the need for a bigger debate and the idea of guidelines and wider support to help decision makers. Jane, I don't know if you had a final thought. There's a question here that might seg into it around, given all the experience of changes in the way of working, including in ICUs we've seen during the pandemic, what messages and lessons really are there and how to change attitudes going forwards?
I mean, I think there are a huge number of messages, and we've learned an enormous amount as we go through. I think there are some areas that just need to be talked about. We need to have some thinking, some workshops. We need to work out what worked and what didn't work. And we also need to talk to the government in the future about how we can improve the situation for doctors. So one of the things, because we're talking about legal things and ethics, is that the law on gross negligence manslaughter perhaps needs to be looked at, because that is a fear for a number of doctors. And as we move forward after the pandemic, that needs to be part of the discussion. If you look back at the case of Hadiza Bawa Garba, and you can see that although there were a number of reports at the time, and although what was suggested in those reports was good and was accepted, a lot of it hasn't been done. And that seems to have been a theme from what we've been talking about today, that there have been reviews, there have been reports, but the reports seem to perhaps gather a bit of dust on the shelves. And the implementation of the findings in these reports to better support the NHS workforce and indeed the patients through that would be something worth going through, just to make sure that those very sensible implementation plans that were accepted are now actually done. I suppose my final point is about the workforce in the NHS. The NHS workforce has really, really struggled. We need to fund it and staff it properly. We need to have a review of what kind of workforce planning we have. Now, the NHS People Plan has, the first half of it has come out, but it didn't have very much in relation to numbers. We need to really look carefully at that so that we have a workforce that has some backup and that has some space and that is protected by having enough people around to do their jobs well.
So Jane, thanks very much, and also to Moosa and Tim for some wonderful contributions. I'm sorry we didn't have more time for your insights, and apologies to people we haven't been able to get through all the questions, but hopefully we've touched on to some of the really core and important messages, and particularly lessons that need to be learnt going forwards. So thank you for your participation. Thanks everyone for watching. A reminder, the next episode in this discussion will be on Thursday, the 18th of February, to cover effective treatments for COVID-19 with Paul Glynn, a consultant physician at University College London Hospitals. Thanks very much for joining us, and keep healthy.
Pleasure.
Thank you.
Thank you.